Okay, so our last speaker today is George Matos, who you heard earlier today, and he's going to pick up on the theme of reattaching the focus.
Thank you very much, Will. And once again, thank you, Dr. Bellin and Will, for allowing me to be here with you folks today. So I'm really excited because everything that's been mentioned here, I'm going to hopefully I'll be talking about as well. So actually, I took one of my slides has some of your information, and Tim, same thing. So let's start off with this. Everyone stand up, please. If you were there this morning, you know I like to get people standing up. Now, talking about some of these positions and posturing, I'm going to get you or ask you to find a partner, and I want you to go back to your partner. If you're a tall or short person with someone opposite to you, I apologize in advance. If you don't like touching people, I really apologize in advance. So back to back, if you don't mind, back to back. Yeah. John, are you alone? Come over here. You have no friends, I'll be your friend, it's okay. So what I'm going to ask you to do first of all, is I'm going to get you to go back to back and touch the back of your hands to each other. So the dorsum of your hands. Just, touch them back to back. Now I want you to, I'm just going to be facing him. I want you to open up or abduct your fingers if you please. Okay? Now I want you to touch your wrists together. Touch your elbows to each other. Touch your shoulders to each other. Yeah. Oh, everyone's standing up straight now. Look at that. Now what I'm going to ask you to do, if you can, of course, if the person is taller or shorter than you, be careful. I want you to bring your arms out to the side like a sunshine. And keep going as high as you can. Wait till the person taps out or says no. Go as high as you feel comfortable, and then come back down again.
That was hard.
Okay, you can have a seat. That's just to get you from, thanks, John. To keep you from sleeping on me while we're doing this. So if you guys want, as your first thing in the morning with your staff, you guys can get each other all nice and cozy together and start rubbing up against each other. So I have no affiliations. So we're talking again about reattaching the focus here. If this is a repeat, I apologize. But I think sometimes when we talk about injury, we forget the basics. So we forget actually what's going on with our bodies. So we're talking about ligaments. We're talking about joints. We're talking about soft tissue, right? The other thing I want to talk about is degrees of injury. You know, first, second, and third degree, things you're all familiar with. But again, I've heard mentioned time and time again, we have an ache or pain, we ignore it, we keep going on. Why? It'll get better. 20 years later, it didn't get better. And we have to start recognizing what our body is telling us. Our body is telling us there's an ache or pain for an actual reason, not because it just likes to remind us that the nervous system is functioning still. Who here actually ignores pain? Show of hands. Or ignores discomfort? Okay? Who here medicates and tells it to be quiet?
Sometimes.
Thank you for your honesty.
Yeah.
Again, we need to start recognizing if there's an ache or a pain, we need to start looking at what is going on. So some of the common injuries, neck, shoulder, back for sure. But even something as simple as carpal tunnel, we can try and avoid these things from happening, even though they're not reported as top on the list. Some of the angulations I've seen with some of the practices, we're into a lot of radial deviation, a lot of wrist flexion. And when we're doing that with compressive forces, when you're pinching or when you're grasping your equipment, that can lead to that carpal tunnel irritation. Even tennis elbow, something as simple as working on your forearm range of motion is very important and very key. Who wants to be a volunteer? Mr. Mark? I'll get you to stand, please. And I won't get everyone to do this because I don't want you guys to poke each other in the eye again. So we're going to stand like this, if you please. Okay? So a horse riding stance, if you will. Now what we're going to do is you're going to bring your palms up to your chest, and as you come up, turn your palms away, and you're going to do essentially probably 20 circles of the thumb around the wrist. As you're doing these 20 circles, you're just trying to work on that range of motion, and you're going in that sunshine motion. As you come back up again, and do this again. This is to work on some shoulder range of motion, also wrist range of motion, making sure that that circumduction is available at the wrist there. Okay? Thank you very much. I appreciate that. Shoulders, rotator cuff. Let's talk about what's happening over here. How often are you folks doing this?
Lots.
Quite. And if you look at that attachment point of the muscle onto the humerus there, it's always in a sort of elongated or extended position. Now let's add on to that someone who has poor posture. So now that rotator cuff is always in that lengthened position. And let's say that you go to adjust or move something, or you go to pick up a little one at home, or you go in to do some kind of a task. If that rotator cuff or that musculature is constantly in an extended position, why is it so obvious then, or not obvious, that that muscle gets irritated or even torn, if you will? So again, thinking about those neutral positions, we're going to talk about neutral spine momentarily, but I just want to bring this up to you, is being aware, because you can't eliminate this risk, right? We said, if you can't eliminate, mitigate. And so if nothing else, at least be aware that this position over the course of time will irritate or potentially hurt or harm me. So again, thinking about that. Vertebral discs, disc injury, herniations, cervical, lumbar. Anyone here, back injury? Low back, neck? Let's remind ourselves once again about those disc herniations. They either occur acute or chronic. So acute can be slip, fall on your tailbone. One of my clients did that. He was carrying logs back and forth. He had plywood down because the mud was, it was all muddy that day from the cabin to his vehicle. And finally, when he slipped on the mud, he was holding some logs, burst fracture, T8. Acute. Chronic. Constantly bending forward, constantly bending forward. And what can happen there, when you look at the superior view, that nucleus pulposa, it starts to migrate its way down. Whether it goes posterior, lateral, right, left, we don't know. It's not like, oh, that L4, L5, posterior, lateral, distal. You know, it doesn't work that way, obviously. But once it finally hits that nerve, then you're like, oh, why are things sore? Why am I having this numbness or tingling? So how do we counteract that? Again, we have to bend forward. We have to do those things. And I kind of mentioned this. Hope I don't offend you, Mark. Spend some time in extension. Okay, maybe not in front of 150 people. But if you can, spend some time in working into the opposite, again, of that forward flex position we always are placing ourselves into. Especially after a long day of work. Whether you're working at the office or you're cutting the grass, what's the first thing someone does, right? I'm tired. What do? So I've just spent my whole time doing whatever I'm doing with my back in a flex position. Now what I'm doing is I'm allowing for that creep to occur more. Because think of it this way, right? If your vertebrae are two dinner plates and that disc is a balloon, if I keep pressing those two plates forward, that balloon's going to want to migrate out posteriorly. Eventually something's going to give. So after your hard day of work or a hard day of working in the yard or what have you doing, think about spending some time on your tummy. If you're going to do anything, spend some time on your tummy, and you don't have to go into a cobra stance. Even the slightest bit of extension at the spine will help at least mitigate or counteract some of that forward flexion that's been going on through the course of the day. Again, my point is it doesn't matter what stage of that injury, any injury. So long as you're alive, little secret, you will heal. Been there, done that. Sometimes those injuries become so traumatic, you're like, this is never going to get better, but it will. How does it get better? It's for us to create the best environment for healing to occur. Because we know, you medicate, all you're doing is masking what's going on. And what happens? 3 weeks, 3 months, 3 years later, it's getting worse because you try to do more when you're medicating. And that medication becomes a part of your lifestyle. So we need to try and eliminate that. Find the cause of the issue. End plate fractures. The end plate, essentially, we're looking at a structure between the disc and the vertebrae. Best described as a mesh structure. And because we know that the disc is avascular, we're relying on that vertebrae to draw nutrition from, and that comes via the end plate. So again, we're talking about poor posture, poor positioning, overloading the spine. What ends up happening? That mesh material, think of it of sort of clogging up with scarring. Now the body's going to heal, but if we're constantly doing things with improper positioning, that can lead to fracturing of the end plate. Again, thinking about those structures within our body, thinking about what are we actually doing to ourselves. And it's not just ignoring that pain, because those are your body's sensors saying, hello, wake up, take care of yourself. I want to get you guys to try something, okay? You've never seen the belly stick out before? If I can ask you folks just to please stand up, take a sit aside, and sit back down again. Just simple. Step to the side and sit back down again. Okay, pretty simple. Sit back down, no issues. If I offend anybody by my next comment, I apologize. Who here practices their pelvic floor stabilization? Kegels, 1, 2, 3.
All the women in the room.
Well, you know what? I've had some people say, usually it's the man, that's when you just sort of hold yourself. Well, not with your hands anyways. So Kegeling, pelvic floor stabilization, drawing your genital anus up in. Yes? Not one person saying, one guy saying yes in the back. Thank you very much. Okay, Now, if I hear somebody fart, you're pushing the wrong way, just so you know, okay? So, having said that, I'm going to get you guys to try a couple of things here. Number one, you're going to contract your abdominal muscles. You're going to pelvic floor stabilize, Kegel, if you will. And you're going to keep breathing, because I don't want you to pass out on me. So, thinking about the previous task of just standing up, taking a step to the side, and sitting back down again, I'm asking you to do these three things. Kegel, pelvic floor stabilize, abdominal contraction, keep breathing, and on your own, please stand up, step to the side, and come back down. Don't lose any of it. Keep it all tight. Don't lose it. OM goodness, look what's going on here. So who felt that that was still easy or more challenging? Challenging?
Yeah.
Okay. Usually what I see is this. Usually the person will, you're sitting down. Oh yeah, what do you want us to do? Stand up, step to the side, yeah, no problem. Okay, now I got to do this, contract, okay. And then they get up and they're like, doing one of these to come back and forth again. What that's telling me is there's your basic back rehab program. Our body is designed to corset itself, not an external weight belt, nothing of that nature. And if we're having a hard time even being able to stabilize just those basic internal muscles that corset our body, that's what you need to start practicing with. So again, being able to keep it tight. No, I'm not expecting you to keep it tight 24 hours a day. That's not the idea. But just to have that neurological ability from the nervous system to tell the muscle what to do and still be functional with it. $10 if you can do that. So we talked about risk factors, and risk factors were brought up in the surveys as well. And we've identified risk factors with the awkward postures, right? The bending, the twisting, the gripping force. This is what Ashley was talking about, but I'm not going to go into it because you did a better job than I can ever do talking about it. I'm just going to pass this over here. So another thing I want to talk about is this neck positioning. All day long, we're always looking forward, yes? Who has neck pain? Pain in the neck. Significant others at home don't count, okay? Just telling you. So what do you do for neck pain? Anyone? Head back, tilt, look up. Stretch. I was talking to someone earlier today. I'm going to get you guys to try something with me. Place your hands like this if you please. So just find sternocleidomastoid. Okay? Keeping yourself in line, and your mouth can be closed teeth to teeth, but not really hard. Now what you're going to do is you're going to strip down to your clavicle, and as you're doing that, I want you to look up. Myofascial stretch. Repeat again. Go back into your neutral with your cervical spine. As you look up, strip down to your clavicle. Repeat that 2 or 3 times on that side, and don't be scared to give yourself a hickey. I won't tell anybody, it's okay. Same thing on the other side. The whole concept of trying to loosen up the fascia on the anterior aspect is so important, because what do we do when we have a sore neck? We do this. What do we do when we're on the phone, when we're doing everything? It's always like this. So again, we need to counteract that. When you go for massages, I mentioned this morning, get them to work on the front. Get them to work anterior positioning of the shoulder and the bicep. Pecs. What causes the clicking? That can be a lot of different things. Too much mousing? No, just kidding. No, the clicking could be tendon. It could be gas release from a joint. It could be a million different things. If you want, we can talk about it afterwards, though. Neutralize postures. Again, this is at the beginning of the shift, and that's at the end, right? Let's look at the shoulder once again. Do we typically stand like this, or we try and stand like this? And people, I've seen so many stand with that anterior rolled shoulder, end up having a pec shortened up, rotator cuff extended. Even looking at the cervical spine, once again, that protraction position, all the anterior musculature and fascia shortens up. Even looking at the low back and the pelvis and how we tilt. All these things are detrimental. So it's how we even carry ourselves. So how do we find neutral spine? Because all of us are different heights here. Everyone stand, if you please. Now, I really ask you to be careful with your neighbors not to poke someone in the eye here. So you're going to start off with your hands like this. Shoulders relaxed. And you're going to you need to maybe go sort of front to back so you don't hit anybody to the side of you. You're going to place your hands onto your shoulders. Elbows in front, shoulders relaxed. As your arms come out to the side, let them slowly come down. Now, if you feel like you're really doing one of these or that feels really awkward, chances are your proprioceptors are telling you that you're used to standing like this. So we need to start practicing here, here, and out. So when you come in to see your patients, you can say, yes, look at my posture, okay? You can have a seat, please. But that's a basic way to find what your neutral should be. If you start noticing by just trying to hold yourself up tight that your back is uncomfortable, well, guess what? Those extensors are probably not used to functioning as they should. Another key reason why to start practicing neutral position. So when I was doing some observations, I was noticing a lot of times, yeah, it's just a quick phone call, just a quick phone call, just a quick ... And this is what ends up happening. We end up being in this forward flex position at the cervical, at the thoracic. Talking about that angled eyepiece you were talking about there, Dr. Bellin. This piece right over here. I think the incline is 20 to 30 degrees. It's a start. And sometimes we have to make those investments into the workplace. Now again, you can have all the ergonomic equipment in the world, but if we're not using it correctly, that's an issue as well. So, other things to pay attention to, using a headset when you're dictating, or if you're receiving phone calls. The amount of times I see this happening, astronomical. Then people don't realize, why is my neck so sore? Why is my right shoulder so elevated compared to my left side, or what have you? Other things that you can do is adjust the height of that table, not only to your patient, but to yourself, and this was already mentioned as well. It's taking ourselves into account. It's not just what's best for the patient. The patient's there for a few minutes and they're gone. You're there all day long. Wrist posture is really important. Now, again, these are generic pictures. Even for something like this here, adjusting the chair, adjusting the height of the keyboard tray, those are all things that you can look at. Now, how does that affect what you guys are doing? Looking at certain wrist positions, these are true issues that we have to be addressing. So, again, when possible, not because you can't always make the corrections, but if you can mitigate, not eliminate, if you're having to do this, if you can even step a bit more to the side or have the elbow bent a bit more, that might reduce the amount of radial deviation. So let's just exaggerate right now. If I'm doing one of these, and if I can draw myself like this, that takes away some of the degrees of motion at the wrist joint. May not always work, but it's an option. And I'll tell you right now, no solution anyone gives you will work 100% of the time. Everything, if you can even do it 20% of the time for the rest of your career, that's better than not doing it at all. So, computer workstations, one nice option is if you can get some arms set up for the monitor and for the keyboard, at least this way you can kind of face your patient a little bit, as opposed to, I think Timothy had a picture where you're rotated more. So if you can bring that equipment where at least the patient is a little bit more into your line of vision, it's an option. Standing workstation heights, they're great if they're being used properly. So you can have an adjustable workstation, and just over here the individual is showing me about trying to get down to the mouse. It's an adjustable workstation, but you need specialized equipment to adjust the workstation. So how functional is that? And who's going to actually take the time? If you have something like this currently in your facility or your clinic, perhaps even spend a few minutes ahead of time, adjust it if you have, say, 2 or 3 days in a row. Again, there's no point having nice equipment if you're not using it properly. And look what's happening. I just drew some lines to the midpoint of the body at the lumbar, thoracic, and cervical. Right? It's one of these, just to get yourself down to the mouse. Who has time for adjusting ergonomics? Same person's going to have to make time for rehab afterwards. So this is what Dr. Bellin was also making reference to. At times, if you find that you need to reposition yourself, even drawing one leg back as a temporary way to sort of release some pressure into the hip or to allow you to lean forward, you can still maintain a relative neutral spine. So again, not going to work 100% of the time, but it's an option. One leg back one way, one leg back the other way. So these are all different positions that I've seen in the operating room. Which ones do you think is the best? None, ideally. None, because we're not designed to stay in one static position. We're designed to move. Of course, if you can stay more upright versus more of a slump, that is better. That is the lesser of two evils. But keeping in mind, we are designed to move. And all the recommendations about physical activity and moving, you can never stress that enough. It's so important to ensure that we are creatures of constant movement, not robotic creatures. Don't move. So again, if you can do anything like having an elevated surface to rest your feet on, anti-fatigue mats, stools, when you're in the operating room, anytime you can do that, it helps. It's not just the old saloons that the cowboys used to put their feet on to drink on. There's a reason. Mind you, I'm sure that helps people stay at the bar a bit longer too. So let's just test your knowledge quickly here. So what's an MSK? MSK injury, right? Musculoskeletal tendon, ligament, of course. What's a risk factor with your profession? Repetition. Awkward positions, thank you, okay? What's one type of ergonomic item that can use to reduce some of these issues? Pads, angled eyepiece, neutral position even. From an ergonomic perspective, height adjustable equipment. Start thinking about those kinds of things that are available out there. And so what position change, we kind of mentioned this already, would you try to adopt to reduce some of the tension into your body or to lean forward, right? Again, having that leg further behind you, if you will. Do you guys remember who this person is? Not one person? Sesame Street, the cake guy? No? Oh, you guys are all way too young for me. So footwear, really, really important. Although aesthetically pleasing, high heel shoes are not functional. Okay? Look at what's happening at the metatarsals, not to mention what would be happening at the calf. Not to mention when I'm walking my high heel shoes on Saturday nights, okay, my body wants to lean forward. So what's happening with my back? It's having to work that much higher. When we walk, we should have a proper heel strike, right? Off onto the lateral portion of the foot, into the ball of the toe, that kind of idea. So again, just keeping in mind, high heel shoes are not going to be functional in the long run. And these are actual shoes, by the way, just so you know. So the message here is thinking about what planes of movement that you're working in. Because you're not going to wear, of course, a high heel shoe when you go running. You want a functional shoe. Well, that's just obvious. That mentality should be just as obvious when you're at work. You want a proper shoe that's going to work for you when you're working. So being fit for work, I mentioned this a little bit today. The SAID principle, specific adaptations to impose demands. If you're someone who is aware of your body and proper body positioning, when you are in the OR, at least you'll understand that this is not ideal. And you'll understand that you'll try and maintain this, but always try to incorporate that in your life. Not just for a week or for a month until you die. And I say that because exercise and activity is something we should be always doing, not just when we have time. That should be our model, and we're incorporating other things into it, not the other way around. So I also mentioned these muscle groups, and I can't stress enough, rotator cuff and the glute medius. Super, super important. Even if you don't have low back issues or shoulder issues, start working on strengthening those muscle groups. Any questions? Thank you for your time. Question?
George, thank you. I think, hello?
Yeah.
Thank you so much, honestly. We were just chatting here. It's a great talk. And a couple questions I'm hoping you can help us out with. So first is driving. Do you think driving impacts kind of our MSK pain? Often you have a 10-hour day, and you get it right into the car, 45 minutes till you get home, and then you want to sit on the couch, right?
Yeah. I've, in treating taxi cab drivers, I'll give you a quick story. I had one gentleman who came back from Vancouver to Winnipeg, and his seat in his semi-truck broke. And he comes into the clinic like this. And he goes, oh, is there anything wrong with my neck? Or, of course, there was. So what happened, he was compensating for about 3 hours driving like this because the seat broke on one side. So aside from the neck thing that I'm making reference to, yes, I think driving is something we need to be aware of. So even, again, if you just finish your shift, spend a few moments doing some of those exercises or stretches we talked about. And there's research out there saying stretching may or may not benefit. But at the end of the day, I believe in range of motion, and I believe in movement. So before getting into the vehicle for that 45 minutes, absolutely spend 5 minutes, even a few minutes, just working on some of that range of motion to open up the front, because we do spend so much time, once again, like that. And that seated position for the hip flexors, probably not ideal.
We did a little exercise in our OR where in between cases, myself and the nurses would all do a little yoga pose. And we found it not only to be positive because it was easier to hold the position longer for the next case, but it just also makes everyone happier. So
Totally, yes.
A question up here.
Do you have comments for using this guy, texting,
Well, again,
the pain?
I would say if you are going to text, probably use a voice-activated text so you're not spending so much time like this. If you do need to, ideally try to hold your elbows onto your body and try to keep yourself more neutral as opposed to looking down like such. I'm not sure if that answers the question.
And
but
for the harm?
yeah, for the most part, right? Like I said, the biggest thing is the cervical positioning, because I think it ends up being like 80 pounds, 70 pounds once you're into like that 40-degree of flexion, 35-degree of flexion. So texting is not ideal. It's there to make money. It's not there to keep us healthy. That's my opinion.
Next question.
Hi. We spend a lot of time sitting, obviously, in the OR in our exam rooms, and I was wondering whether you had any comments on saddle chairs, and whether you thought they
So-
were of benefit, obviously for the back and perhaps for the neck.
So the concept of saddle chairs, where you're sitting more abducted, if you will, to try and have the pelvis into more of an anterior tilt. Is that what you're?
Yeah, I guess I don't know much about them, but I've
Yeah,
just heard
I would
that,
say again, sitting is sitting. Ideal sitting versus non-ideal sitting is obviously better. That's the mitigation of the risk. But try to reduce the amount of sitting that you're doing. Typically, when we're doing office ergonomic assessments, we'll make reference to no more than 20 minutes of sitting. So actually, Dr. Alan Hedge, he's done a lot of work from Cornell, and he has a model that he goes with. And he says, every 30 minutes, 20 minutes of sitting, 2 minutes of stretching or standing tasks, and 8 minutes of actual paperwork tasks, standing, not sitting. So.
okay. Are there certain chairs that help you get into a neutral position?
Well, the more adjustment the chair has, the better, of course.
Right.
But at the end of the day, neutrality is something that we have to be aware of, right?
Thank you.
For sure. Hello.
I just want to say, in all the years I've gone to sessions, this is probably the most useful one for me as a person. The other ones are great academically, but this is, for me, to take care of myself, has been absolutely amazing. Having said that, all your exercises that you're showing us and everything, my memory is also not that great. By the time I go home and I try to remember everything you've showed us just to stand up and do here, is there any way we can access that?
Yes, I was speaking with Dr. Bell, and we're going to actually have a way for you to have access to that.
So I've talked to the COS, and George will get the stuff to me, and then I'm going to get it put up on the COS website, so it's available that way.
Yes, there's lots out there too, yes. That's all? Okay, thank you very much.
Okay, thank you all for coming. I think this was a really great session. Please do give feedback, and I guess one of the questions that would be useful is whether you think this should be done in future years, and if so, if there's any specific topics that you wanted covered. Okay, thank you.